Hi everyone, this is our first lecture for research methods, and our topic is an introduction to evidence-based practice. So what is evidence-based practice? Essentially, evidence-based practice involves using research to guide practice decisions, and more specifically, it's an integration of the best research practices with your own expertise as a clinician and the client's characteristics. In the context of mental health treatment, this means identifying interventions or treatment approaches that have been shown to be the most effective for the particular issue that your client is dealing with, while being mindful of your own clinical judgment and the particular client's needs, strengths, and so on. So I'm going to explain each of the components of evidence-based practice and then go through a few examples where we can look at the different pieces of information that each component can bring to decision-making. Oops, too far. There we go. All right, so in the article that you've read for this week, the components of EBP are described through the metaphor of a three-legged stool, with each leg representing a data strand that needs to be considered and integrated to determine optimal care for this particular client, meaning to decide on the evidence-based practice to use. The components are here as follows, and we'll go over each in a bit of detail. So first we have research evidence. So research evidence comes from immersing yourself in research. This includes reading journal articles, books, going to training, and so on. Now, after you've read and critically analyzed the accessible research, you would then have an answer about what the research suggests is the best approach to treating this particular issue with this particular individual. Okay, now this tends to be a bit harder than it sounds. And so you spend a whole class on it in this semester learning how to do it. So for example, you might find that TFCBT is the best approach for treating PTSD. But what if your client is a toddler? And what if you're doing short-term therapy or the client can't afford therapy and they only have 4 free sessions? Then you're going to have to drastically modify your approach to TFCBT in order to help it be effective, even though the research says this is what you need to do. Further, there are some types of research that are going to be better at answering the questions that you have than others. So it's going to depend on which type of answer you're looking for. And we'll get into more about this when we do research hierarchies. But for example, if you're looking for best intervention versus best assessment approach, the type of research you access and you use might be a little bit different. And to make this a bit more complicated, you may find that you find contradictory results in the research that you read, and it's not going to be a super clear-cut answer. And this is why evidence-based practice also includes other components, right? So the next component is client preference or client characteristics. And this basically includes your client's individual characteristics, such as their social group memberships, gender, race, ethnicity, so on, their strengths, their needs, and so on. It also includes their preferences, meaning their wants for therapy and their wants from the therapy experience itself. This is why anyone who's taken an assessment class with me knows that I stress collaborative development of treatment plans. Your amazing 100% research-based treatment is useless if your client's not going to do it. And the final part of evidence-based practice is clinical experience or expertise. And this comes from your own clinical judgment, which is derived from your training, your experience, the specific clients that you've worked with, your scope of competence, and so on. This is not, however, your opinion, right? But that doesn't mean that it's any less valid, right? So I would say that this part is the one part that really can't be replaced by anything else, right? You can read lots of different articles, you'll have lots of different clients, but you and what you bring to the table is unique and is important and necessary for effective treatment. All right, so now we're going to try applying these different components or looking at these different components by looking at some examples in physical health, mental health, and an everyday example. So we'll start with physical health. In the context of physical health, let's consider obesity. First, please know I am not a doctor and have 0 medical training, and this is an illustrative example only. Okay, so let's say, for example, you have a child who's overweight. A doctor who's using evidence-based practice would know that the research suggests that exercise and a healthy diet will help the child. However, there's more to it. This doctor should also consider the patient's characteristics. For example, does the patient live in a low-income family where getting nutritious food might be challenging? Does the child have a genetic predisposition to obesity, where this might complicate things a bit more and exercise and diet might not necessarily be as helpful as we'd hope? Finally, the doctor should also consider their own expertise. If they're a pediatrician, they likely have experience with children who struggle with obesity, and they can share things that have helped other families. Like, for example, they may have found in their work with children and families that getting the whole family involved in a diet and exercise plan is more effective. And this is what they can then bring to the table. So these three pieces of the evidence-based practice come together to provide a more effective and helpful intervention, in this case for obesity. All right, next, if we come back to mental health, we can look at depression. So let's say you have a client with depression, and you should know, of course, that there are indeed treatments with strong evidence of efficacy for treating depression, such as CBT or CBT in a combination of antidepressants. But you would also need to consider this client's characteristics. Perhaps they have an artistic strength, for example, that might be useful as a coping strategy and could be added into your CBT treatment. You should also use your clinical judgment and know that depression manifests differently in different people. So sometimes what we think about like high functioning depression. So you'd want to take this into consideration. You may also have knowledge from your own expertise of certain activities or interventions that have been effective in your own practice that you may choose to integrate into your approach. Okay? Of course, this is an oversimplified example, but you can see how these things can kind of integrate and work together, again, to create a more effective intervention. Okay? Now, hopefully this is becoming a little bit more clear. But if not, know that you actually do evidence-based practice most likely every day. So think about when you're trying to figure out which restaurant to get takeout from, right? You likely will consult research through things like Yelp, right? Or by asking experts in the field of eating good food, and this research will give you a recommendation, right? But you also would consider your own characteristics. For example, let's say you're vegan. Well, then the recommendation from Yelp to get food at the Korean barbecue place by your house isn't gonna work, right? You'd also need to consider your own expertise. You may happen to know that restaurants can pay to suppress negative reviews and to boost positive ones. So when you do find, in this case, a vegan-friendly restaurant, you're going to scroll through the positive and negative comments just to make sure, right? And through this process, you'll settle on a restaurant. And that is you doing evidence-based practice in your everyday life, right? And for a good vegan restaurant, probably Sage in Pasadena. All right. Now, before we end, I do want to take a minute to clarify some terminology that you may encounter in your reading and will very likely encounter in your practicum. So EBT, ESC, EST, and EBP. So EBP, evidence-based practice, is the one that I've been talking about with you. It involves using current best evidence, clinical judgment, and client characteristics in order to make decisions about treatment. And this is what we're going to be learning about primarily in this class. This is different from evidence-based treatments, EBT, and empirically supported treatment, EST. But you'll notice even in my PowerPoint that I've switched up some of the letters sometimes because there is so much overlap. But I'm going to tell you the differences. So EBT or EST involve manualized treatment approaches or protocols that have been backed by scientific evidence. These are called EBTs or ESTs because research has shown that if you follow the manual or the protocol with fidelity, this treatment is proven to have a significant impact on mental health outcomes. Now, the word proven is a big deal. In order to prove something is effective, you need to conduct experiments using it and comparing it to something else, ideally no treatment, and showing that it makes a difference. But there are many reasons why this is hard to do in mental health, and we'll discuss them later in this class. For now, just know that it's not easy to do this. Now, the big push for these EBTs or ESTs, these manualized treatments in California, started about 10 years ago during what's sometimes called the age of accountability. Essentially, we wanted to make sure that what we were doing in mental health was actually making a difference. And this led to discontinued funding for what were considered ineffective programs. But it's important to keep in mind that even though there are indeed some programs that are ineffective, like we know that the Scared Straight programs, for example, are not effective, there are other interventions or approaches that cannot be considered proven effective because their efficacy is difficult or impossible to ascertain. So think about psychoanalysis, which is different for each client and each therapist. It's going to be hard to put that to the test in an experiment and prove that it's effective, but that doesn't mean that it isn't, right? Nonetheless, those that could be proven effective and have a manualized format that can be implemented by different clinicians for different clients are more supported now by things like DMH contracts. And this is why you're likely familiar with commonly used EBTs like MAP, Managing and Adapting Practice, or Triple P, Positive Parenting Program. And these are required for billing many DMH contracts. So to sum it up, what's the difference between EBT, EST, and EBP? EBT is manualized, research-based intervention that's considered the best approach for an average patient, which means it will not work for everyone, and it still requires clinical judgment and taking client characteristics into account. As such, you can think of EBT as one part of EBP, but by no means is it the only piece or perhaps even the most important piece, okay? So to finish, something that you might find helpful as you learn this new information is to practice applying it to a real person or a potential future client, and then work on identifying elements of each of the three legs: research, clinical experience, and client characteristics that would fit with respect to that person. And we'll continue to do this in class. All right. So let me know if you've got questions. We'll discuss more during our live class this week. And thank you for listening.